Sheesh. All right. So I am here in part to address the task that is about knowing what the patient and family experience is. We started the day with Dan Diaz, and thank you for sharing Brittany's story. This talk is based on two empirical studies, one that started over 20 years ago that was funded by the Greenwell Foundation, which I think was one of the first narrative studies to actually ask patient and families to talk about what actually happened. Other than that, it had been opinion polls from actors, but not the direct stories from people themselves. And then I also want to talk about a redo of that study that's going on in California right now. So the first study was done in Washington when it was still illegal, and it was about a year into when the law was practiced in Oregon. And we interviewed 35 families. We followed them longitudinally when we were able to recruit the patient while he or she was still alive. We followed them until the person died. And then in all cases, we followed the families for another year because we were also interested in hearing about bereavement experiences and what this looks like to affect the experience for the family members as well. We published 5 papers out of that, and I'm going to talk about findings from 3 of them. The first one, really, we've talked a lot about why people ask for this, and I think we've heard a lot of good stories, but I want to say that I think as all have indicated, it's very often not a quick judgment. It often is a combination of factors that sort of draw on these three domains, and they weave together to sort of lead someone to think about this as a serious option, and that is the enduring diminishments that come with terminal illness, with any serious illness in which we have a series of losses over time. There is an exhaustion of dying. People get really tired of not being dead yet. That just the fact of living while dying can sap a lot of energy, and that it isn't so much about pain, but it can also be about the side effects of pain medications, and this whole concatenation of losses and capacities include a more existential sort of locus of self, and when you cannot actualize who you have been and what you know yourself to be, that can become a kind of a triple threat. And in addition, there are fears about the future, some of which are sort of a replay of somebody else's movie, that when they die, you're sort of running that past experience through and projecting yourself into it. And others are based on much realistic trajectory of your illness and what people are telling you is likely to happen to you. The second paper that I want to talk about is actually what affected the timing, because in this instance, these were people who had accumulated medications, and then I asked the question, why now? Like, why did you die today when you could have died yesterday or next week? And it really often comes down to where they are in the progression of illness. And for people that are about a month or so, and these are based on sort of guesstimated prognoses had they lived given their clinical situation, they were really just dying for a long time. Some of them waited probably until the day they were dying anyway. They probably would have died whether they took medications or not. But for them, it was really a turning point in this idea that they truly did want to assert their own self over the disease process and not be left a victim to something that felt really not good for them. For the folks with a longer estimated prognosis, it was really the fears about the future that really characterized why they chose to die when they did. I think things that I think Francis just started talking about families, but the laws protect a lot of people, but they really don't invoke much around families. And I think it's important for us to think about what that means, because this is, as everyone has said, you see this gigantic flow chart about what it takes to get through all of that. Often this is happening when people are quite ill, and they're very rarely doing it alone. And there's not a lot of guidance. The one thing people are told is to have the family leave the room when we have this conversation so that there's no coercion. But often what happens during that conversation is when there's education about what the process is going to look like, and the families then miss out on that, and they actually aren't as fully informed as they could be. So they're scrambling to sort of figure out what's going on. They participate in pretty much everything in the process, from the beginning planning and logistics to getting information, doing internet searches, finding medications, finding willing providers, being present at the death. Almost all of the mixing of the medications is being done by family members, not by the patients themselves, who are usually too sick. And in places where it was illegal, if there were backup plans because of a failure of medications or something else, the family members were implicated in doing that as well, or they did not, and the person didn't die of the physician aid in dying. But by and large, certainly in the circumstances where it was illegal, families felt very isolated and very ill prepared. My stance personally was that I was sort of neutral, but this study sort of put me in the direction of legalization because it mandates that people get involved and have a protocol and actually get engaged, and people therefore have access to information, which they were trying to figure out on their own. And I would say that this is probably still happening in places where it's not legal, but that is not a barrier for families. If they express an interest, they will find a way. But fast forward to last year when the California Healthcare Foundation and the Stupsky Foundations joined forces to fund this project. I'm sure you'll hear more about it. There are 3 aims, one of which we've completed in convening in September. My colleague Barbara Koenig will speak about that later. UCLA is also doing a parallel study where they've been recruiting surveys from institutions across California to see what their current policies look like so that they can talk about who's in, who's out. And the third one is a repeat of this narrative study. And we are currently with 21 families. We have recruited from pretty much across the state, 12 retrospective, meaning the families reported after the patient had died, 9 prospective, in which we heard from 8 because one patient was aphasic and couldn't speak. We've had 25 physicians who have been involved in these cases across 7 health systems and 4 community-based practices. These are the demographics, typical sort of what we are seeing, a mix of cancer, mostly cancer, but some neurologic and sort of system failures. We still have 5 folks alive, and 14 have used the medications. And there's a mix of what the drugs are still. So we are still seeing Seconal is the leading choice, but there is a few folks that are using this other new medication combination, the DDMP. But it looks like, at least from the people that we've heard from, granted a very self-selected sample, a pretty similar range, both in terms of how long it takes to die, and but the cost differences are significant. There are certainly challenges with access where about half of the patients that we heard from were able to follow the process through within their own health system, but that didn't mean that the first person that they asked was the person who wrote the prescription. We have heard from many that that the opt-in rate by oncology is very low, and so while the majority of patients have cancer, the majority of the people writing the prescriptions are not oncologists, which means that they need to have a network somehow within their system to find another person who would be willing to fulfill that. So this I find to be a sort of an interesting piece where the law was written with the intention that you would be having these conversations like in the Netherlands in the context of a long-standing relationship, but the opt-in and opt-out means that a lot of those patients are meeting someone for the first time with this request, whether it's in their health system or not. So what we found with the stories we've heard is that the health systems that have a navigator make a huge difference to the patients and families in terms of working through this complexity and connecting the dots. There are some that have navigators that are information only and they won't do any matchmaking. And then there are others that are take it incumbent upon the system itself to find willing providers. There, however, are still problems in terms of what counts as a first request. So when the oncologists are hearing, you're out of options, and the patients are saying, great, then I want to start Death with Dignity, some are saying, and others are saying, okay, here's who you call. So it doesn't necessarily turn into a formal request at that point, and that is up to the subjectivity of the clinicians hearing the story, and it doesn't always manifest in a smooth process. When there is some stalling, then you find that there is more of a mix where people are going outside, and it's almost always to try to find an attending physician. So when patients are still able to access a willing provider inside their system, it is more often a consulting physician who is confirming prognosis, not someone writing a prescription. When they are accessing specialty providers, it's most often after they have failed to find somebody in-house. And then there were 2 who had organ failures or neurologic diseases, strokes in particular, where they could not find a willing provider because of the 6 months. They all could agree this person would very likely die of their illness in some period of time, but couldn't attest to 6 months. So I think a few lessons. This process takes time, and of the people that we've talked to, very few actually got it done start to finish in 15 days. These are long quotes, and I won't read them all, but it really is that you start a process and the bureaucracy gets in the way, and then it just takes a lot of time to churn through it all. The exception is when you are going to what I'm starting to call the destination docs, the people that are doing this either as a specialty within a larger practice, or actually this is their practice. And because of that, they are sort of self-made navigators and they know how to work the system, and you could start on day 1 and be dead on day 15. And some of the patients we spoke to, that was in fact what happened. We found because of this that there's a lot of obfuscation, and for some people it's because it's their first time being asked, and therefore they weren't really sure, and a lot of it was them working it out for themselves with their first request. But what patients were really saying is, let your patients know whether you're on board or you're not. If you're not, that's okay, and if you're ambivalent, that's okay, but tell us up front, because we need to know. And they want the opportunity to be able to go find another provider if this person is not willing to be in that role. And that for some, providers took weeks to months to decide if they were going to participate, and that time was pretty stressful. The family support role was described by several of the family members as being a project manager, and that they were project managing this death, and that wasn't exactly the job they wanted to have. In particular, they were project managing the medications, and there is a lot of existential distress around what it takes to open up 100 Seconal. One family, I said, I really wish they told us. They all draw little pictures. They do this, where they talk about taking a toothpick and getting all the last stuff out. And she said, I practiced with things that had little beads, and it was easy, but no one told me it was baking soda, and we sneezed, and the whole thing went everywhere. There was a family that picked 4 of us because they thought of it like a Russian roulette. They wanted all hands in so that nobody would literally have the dust on their hands. And then on the day of death, there was a particular piece about this project management that they were so fixated on making sure that absolutely everything went according to plan that they couldn't kind of be present to witness because they were obsessed with making sure that everything went the way it should. And as this person said, I feel like I got cheated out of his last couple of minutes because I was helping him with the medicine. So I leave you with those stories.